Okay, let's kick this off. Today we're really diving deep into breast abscesses. We're using some focus notes here, aiming for a high-yield guide for, anyone prepping for the MSRA or just needing a solid understanding.
Absolutely. It's about understanding what they are, the why behind them, and importantly, how they're managed. So basically, a breast abscess is, well, it's a pocket of pus that forms inside the breast tissue.
Pus, right? That thick yellowish stuff.
Exactly. And it's almost always down to a bacterial infection getting established. Sometimes it crops up as a complication if mastitis, that's breast inflammation, isn't quite cleared, or maybe even just from a blocked milk duct that gets infected.
Okay, so let's get into the etiology, the actual cause. This is interesting.
It really is. The main bacterial culprit, the usual suspect, is often Staphylococcus aureus.
Staph aureus.
Right.
And how does it typically get in?
Well, a very common way is through breaks in the skin, particularly damaged nipple skin. You see this a lot with breastfeeding, which is why these abscesses are more common in women who are lactating.
And they show up as these tender lumps, sometimes a bit squishy, fluctuating.
Precisely. Tender, maybe fluctuant lumps.
Mm.
A little memory tip might be thinking staph, like a snag or staph breaking the skin barrier, letting bacteria through.
That's helpful. So connecting that to risk factors, who's more susceptible?
Definitely breastfeeding individuals, especially, like we said, if there are issues with latching or perhaps cracked nipples offering that entry point.
Makes sense.
And having had mastitis or even a previous abscess definitely increases the risk too. But it's not only linked to lactation, other things can play a role, conditions that might affect the immune system.
Like what sort of things?
Think diabetes mellitus, smoking is a known factor, and generally anything causing a weakened immune state. Maybe you remember SMI'd smoking, mastitis history, immune issues like diabetes.
SMI, okay. Got it. So pathophysiology. What's the process inside the breast?
Right, so the bacteria, usually staph, get through that damaged nipple or duct opening. Your body immediately reacts with inflammation, sending white blood cells, trying to cordon off the infection. That's the natural response.
But sometimes that response kind of backfires.
In a way, yes. Sometimes this inflammation leads to tissue breakdown and the formation of a walled-off cavity filled with pus and debris. And that's your abscess.
Okay. Now, this is crucial for diagnostics. How do we know it's an abscess and not something else? The differential diagnosis.
Exactly. You need to think about other possibilities. Plain mastitis is one inflammation, but no organized pus collection yet.
What else?
Breast cysts are common. They're fluid-filled sacs, but typically not infected like an abscess. Then there are fibrocystic changes benign, often lumpy breast tissue. And although it's rare, inflammatory breast cancer is a really important one not to miss, as it can sometimes look similar initially.
So how do you usually tell the difference clinically?
Well, with an abscess, you often get more localized signs, distinct pain, redness, warmth over a specific area, and often that palpable lump that might feel fluctuant, like it's got liquid inside. Plus, systemic signs like fever are more common with abscesses than simple cysts or fibrocystic changes.
Right, okay. And how common are these? What's the epidemiology look like?
If we look at the UK, estimates vary, but it's somewhere in the range of, say, 1 to maybe 11 cases per 10,000 women who are breastfeeding.
So not hugely common overall, but certainly significant within that group.
Definitely. It's primarily seen in women of childbearing age, and particularly those who are lactating.
Okay, let's recap the clinical features someone might present with. What would you expect to see or hear from the patient?
The classic picture involves localized breast pain, often quite severe, and tenderness right over the affected spot. You'd likely see swelling, some redness, maybe erythema, and the area would probably feel warm to the touch compared to the rest of the breast.
And that lump we mentioned.
Yes, often there's a palpable mass. It might feel fluctuant, or sometimes it can feel quite firm or indurated. And as we said, in more significant cases, you can get systemic symptoms, fever, chills, just feeling generally unwell, malaise.
Maybe we can use ProSenti for that.
Mm-hmm.
Pain, redness or warmth, swelling, temperature, systemic or local, and a palpable lump.
Procent. Yeah, that works quite well, actually. Covers the main signs.
So, investigations. How do we confirm it?
It starts with a good clinical examination, looking carefully, feeling the breast tissue. Blood tests can be helpful, looking for raised inflammatory markers like CRP or white cell count, and sometimes blood cultures if sepsis is suspected.
And imaging.
Imaging is key. Ultrasound is usually the first choice. It's really good at showing the fluid collection its size, location, and helps differentiate it from solid masses or simple mastitis. Mammography might be used sometimes, perhaps in non-lactating women or if there's any suspicion of underlying malignancy, but ultrasound is generally preferred for abscess evaluation.
Okay, ultrasound is the go-to. Now, management. What's the plan?
The cornerstone of treatment is drainage. You need to get that pus out. This is typically done either by needle aspiration, using a needle and syringe to draw out the pus, maybe needing a few attempts, or by incision and drainage.
Incision and drainage. A small cut.
Yes, a small surgical cut made over the abscess, usually under local or sometimes general anesthesia, to allow the pus to drain freely. Sometimes a small drain might be left in for a short period.
And antibiotics, too, presumably.
Oh, absolutely. Antibiotics are crucial to treat the underlying bacterial infection. The choice might be guided by local guidelines initially, and then possibly tailored if we get culture results from the pus. Flucloxacillin is often a first-line choice if Staph aureus is suspected.
And what about breastfeeding? Should the mother stop?
Actually, no. Continued breastfeeding or milk expression from the affected breast is generally encouraged, believe it or not. It helps to maintain milk flow, prevents engorgement, and can actually help resolve the inflammation quicker. It's safe for the baby, too.
That's really important advice. Okay, so what's the outlook? The prognosis?
Generally good, thankfully. With prompt drainage and the right antibiotics, most breast abscesses resolve well, and women make a full recovery.
That's reassuring. Are there any potential complications to be aware of?
Yes. Like with most things, there can be bumps in the road. Abscesses can sometimes recur, unfortunately. Occasionally, you might get the formation of a fistula, which is like an abnormal tunnel connecting the abscess cavity to the skin, or a sinus tract. Breastfeeding might become challenging, understandably, and there can definitely be a psychological impact, too. Pain, anxiety, maybe feeling discouraged about feeding.
Yeah, you can see how that would be tough.
It can be.
So, wrapping this up, understanding breast abscesses really means knowing the triggers, like the link with Staph aureus and nipple damage, recognizing those key features, the pre-OST signs, and appreciating that prompt drainage and antibiotics are key.
Exactly. Early recognition and treatment make a big difference to the outcome.
We've covered quite a bit here, from the definition right through to potential issues. If you want more detailed resources and specific MSRA prep materials on this and other topics, do check out pastthemsra.com.
And for loads of excellent free learning materials to support your revision, freemsra.com is another great place to go.
Definitely check those out. And just a final thought to leave you with. Knowing how strongly linked nipple trauma during early breastfeeding is to this condition, what kind of simple, proactive advice regarding nipple care could potentially make a real difference for new mothers right from the start? Something to consider.